I hit record.
So Africa looks like it was so much fun. You went to a few countries, right?
In the summer I went to like 7.
So I started.
In the winter I went to just 1.
We're starting?
Yeah. Okay. All right, guys. So it's like 12:06. I'm gonna get started. I hope that this presentation won't take the whole hour, but I want to leave time for questions and stuff at the end because I hope you will have them. So welcome to FMIG's first lunch meeting of 2019. I'm Jordan. I'm the current FMIG President. This is Maggie. She is the current FMIG right-hand man. I'm not sure.
I don't know what my title is.
We're both 4th years going into family medicine, super passionate about it. And I wanted to give you guys this talk today because this talk is full of things that inspired me to go into family medicine, but it's also full of those same things that nobody told me about family medicine, specifically in my first 3 years of medical school. How many of you guys are first years? Okay, so I don't know if you've noticed yet, but you will notice that the hidden curriculum at Southwestern does not actually really encourage students to enter primary care specialties, despite the fact we have some incredible and amazing and super engaging family medicine faculty and staff here who are really working on changing things. But the fact of the matter is that if I hadn't been super lucky to stumble into some opportunities with doctors here and then also doctors in the community, nobody would have told me any of this, and I would not have known all about what family medicine as a career has to offer for our patients, our societies, and our own personal fulfillment as physicians. So, let's go. All right, so the history of family medicine is the history of all medicine in general. So way back in the 19th century, in the 1800s, most Americans lived in small towns and all doctors were generalists. These generalist doctors were just members of the community. They knew their patients well, they knew everybody in their family, and they did everything for their patients. So they delivered babies, they did minor surgeries, they took care of complex medical conditions, and they did all of this in exchange, not just for money, but for goods and services as well. So most of these doctors were good, and they were reputable, and they knew what they were doing, but a lot of them were quacks, because it's really easy to exploit the basic human need for healthcare, but B, there was no formalized, standardized method of training for physicians. There was just these informal apprenticeships. But as we move on through the 19th century into the 20th century, and our societies became more and more industrialized, and our cities got bigger, the general feeling in America was that as we moved into these higher population centers, is that we really needed to systemize our medical education because it was lagging behind that of European countries. And so the powers that be got together and they decided that we needed to affiliate medical education with universities, we needed to focus on a strong basic science foundation, and we needed to rely on training by faculty in these universities who were heavily involved in research so that we could create learned doctors. So the American Medical Association was founded in 1846 to further these goals to standardize education. And as the American Medical Association evolved to further these goals and do things like set standards for public health and cleanse the profession of quacks, in doing so, it also kind of gave rise to this culture of institutionalization and specialization as a collateral for reinforcing the scientific and academic rigor. So what happened was, as there was this push towards cities and towards standardization of knowledge and training, the medical bureaucracy gave rise to things like specialty board associations. It gave rise to organizations that would eventually become the American College of Graduate Medical Education, which does residency programs, and it gave rise to state medical licensing boards. And all of these bodies, while serving an important purpose to standardize medical education, they're also bureaucratic, profit-driven organizations that centered America's focus in their developing healthcare system not on nationalization of their healthcare system and not on things like social responsibility, but things like profit and prestige and specialization and institutionalization. And so what had previously been known as general practitioners, these old-timey country doctors who knew everybody in town and did whatever their patients needed, were increasingly looked down upon because they had no formal method of specialization and they were not welcome in the cities. They were not welcome they were not encouraged to work in hospitals, they weren't allowed to perform procedures, and they weren't allowed to participate in other clinical activities in these growing medical institutions. This divide was furthered because as this push towards cities and specialization and standardization happened, the cost of medical education increased enormously as well. And as the cost of medical education increased, it increasingly became a career of the upper and upper middle class, right? So whereas previously you would have these general practitioners who were anybody from the community, regardless of socioeconomic status or background, that population started shrinking. The population of rural, small town general practitioners shrink, and the population of city-based specialists started to grow. And so as this kind of shift was happening, and as medical schools became more selective and more prohibitive to enter for a variety of social and cost reasons, this was occurring from 1920 to 1960. Over that period of time, medical education enrollment did not significantly increase, and the population of America significantly increased. And so this is like what led to our doctor shortage. So this brings us to the 1960s. And when we think of the 1960s, right, we think of the civil rights era, we think of people taking on this increased sense of social responsibility and getting fed up with the status quo regarding a lot of issues of social justice. And what I kind of failed to explicitly think about before somebody told me this is that access to equitable and quality healthcare was and remains a civil rights and social justice issue. So in the 1960s, as part of this ongoing civil rights movement, the American public came to the AMA and started to express their dissatisfaction with the modes of healthcare delivery in the United States. They were like, hey, we have a shortage of physicians, we have inaccessible healthcare, it's too expensive, it's too impersonal, and we're getting our care in all these different places from all these different specialists, and it's leading to poorer outcomes. And so, in response, the AMA was like, we should do something. Well, we'll start by funding education to medical schools, and then we'll also create a couple of committees to investigate how we can best solve these 5 issues for America's healthcare system. The American Public Health Association also formed a committee to investigate this, and each of these 3 committees came up with an independent document that they each published throughout the 1960s, through 1966 to 1967. And so the first one from the American Medical Association is the Millis Report, and it said, hey, to solve all these problems, what we need is a doctor who focuses not upon individual organs and systems, but upon the whole man or woman, who lives in a complex setting and knows that diagnosis or treatment of a part often overlooks major causative factors and therapeutic opportunities. So that was the first one. The American Public Health Association came to the table and was like, hey, we thought about this too, and we think that every individual should have a personal physician who is the central point for integration and continuity of all medical services to his patient. Such physician will emphasize preventative medicine, he will be aware of the social, emotional, and environmental factors that influence his health, and he will care for the whole patient and his family as a whole with continuity. And then finally, the AMA's second committee came back and kind of cut to the chase and said, the American public does want and need large numbers of family medicine physicians to solve these problems facing our healthcare system. And so this period of civil unrest, the 1960s, marked not only by dissatisfaction with healthcare, but also by things like the Vietnam War protests and the women's rights movements and racial equality, ushered in the right atmosphere for the new creation of this socially responsible counterculture specialty called family medicine. And so in 1969, the American Board of Family Practitioners was created. In 1969, family medicine became a specialty. And in 1970, the American Board of Family Practitioners had their first board exam. So moving on from the 60s, in the 70s and 80s, family medicine really had its heyday. You can see this. This is the only graph I can find in this information. So we're zooming in on a tiny portion of it. By the 80s, there were over 300 family medicine residency programs, over 100 medical schools that had family medicine departments, and it was the 3rd most popular specialty for graduating United States senior medical students. Also, I couldn't find a graph to represent this, but the data is there. Income for family medicine physicians was also rising rapidly during this time as their desirability increased and more students wanted to choose family medicine. So this brings us to the 90s. As healthcare inflation grew, let's see, I'm sorry, my computer got messed up here. All right, so as healthcare inflation grew, the managed care revolution promised to fix not only the way that healthcare was paid for, but the way that healthcare was delivered. So what is a managed care organization? Managed care organization is basically an HMO. I'm sure you guys have heard of HMOs, but you might not know what they are. So it's a health maintenance organization. The most famous example is Kaiser Permanente in California on the West Coast. And in this system, patients get unlimited access to healthcare in exchange for a set subscription or capitation rate. And then they agree to only see certain doctors in certain hospitals. So the idea behind this is to get the healthcare market to evolve into these tightly integrated delivery systems that rely strongly on a gatekeeper network of primary care physicians who will keep costs low and prevent unnecessary or expensive care by providing preventative measures and knowing the patient really well. This was accomplished through the establishment of what were called risk contracts, in which the PCP or the group PCPs said that they would be responsible for all excess costs incurred by the healthcare of members in their practice, which means that PCPs were going to be responsible not just for primary care costs of their patients, but also emergency room pharmacy and hospital costs, which in turn would de-incentivize unnecessary escalation of care and reduce healthcare costs while still providing quality care. So this all sounds good, but this did really not go over well with the American public, who were really used to employer-based fee-for-service insurance models of unlimited healthcare access and getting to choose your providers, and unlimited access to specialty services. And so because of this, primary care physicians started to be viewed really, really poorly by the public, as well as other physicians, for their gatekeeper role in the managed care organization era. And so not only this, but during the 90s and early 2000s, the American economy was booming basically, and this meant that unemployment was really low and the labor markets were really tight. And so to attract and retain employees, employers started moving away from these HMO models because people didn't like them, and they moved more towards more loosely managed care models like PPOs, so preferred provider organizations, and to open access HMOs who don't have a primary care gatekeeper. So with the fall of managed care organizations, or HMOs, and their associated integration of care models, hospitals started reverting back to traditional competitive strategies that were driven by the market and would attract patients and healthcare workers by offering like amenities such as increased specialty services on demand. And so with this shift, emphases on quality healthcare were dropped. And so when I say quality healthcare, I mean high value at low cost. And who is best trained to provide high value healthcare at low cost? It is family doctors. So this is the aftermath of the managed care era. We can see that it had been dropping a little bit before, but I'm sorry, this is not in sync, so I gotta stay up to date with it. So primary care in general peaked in 1998, which was like the heyday of the managed care era. And at that time, over 50% of graduating medical students were choosing primary care specialties, which means not just family medicine, but internal medicine and pediatrics as well. Of course, you know, it's impossible to know how many internal medicine and pediatric residents will eventually subspecialize, but they're still primary care focused residencies. So we have the fall in family medicine providers. And this brings us to kind of the state of our current healthcare system today. So just to give you guys a brief overview, this is what the United States spends per capita on healthcare, and this is what other countries in their similar GDP bracket spend on healthcare. So other countries of similar income and wealth. And so what do we get for spending twice as much? We get poor insurance coverage, we get really poor health outcomes, we get poor access, and we get poor value, basically. We have these 5 problems still. The exact same 5 problems that we had that family medicine was founded to solve. So, you know, we tried managed care, it didn't work. It left everybody with a really bad taste in their mouth regarding family medicine. And the AAFP was like, okay, well, to bounce back from this, nobody really knows, family medicine doctors, patients, policymakers, nobody really knows what the scope or purpose of family medicine is. Like, we had those 3 documents, they sort of told us what we maybe should be working towards, but nobody has come to a consensus on what the definition of family medicine is. So in 2003, the AAFP came together and they founded a committee, and they came up with this definition, which is still the standard, like gold standard definition for family medicine today, which is that family physicians are personal doctors for people of all ages and health conditions. They are reliable first contact for health concerns and directly address most health needs. Through enduring partnerships with patients, they prevent, understand, and manage illness and they navigate the health system and set health goals. They adapt their care to the unique needs of their patients and communities. They use data to monitor and manage their patient population and use best science to prioritize services most likely to benefit health. And they are the ideal leaders of healthcare systems and partners for public health. I think this last thing, they're all unique to family medicine, but I think this last thing is what family medicine does really well and no other specialty works towards as much. So we know what family medicine does now. We've been over our 5 problems that we have to solve in the United States healthcare system. Let's talk about how and why family medicine will still work to solve all those problems. So we talked about those 5 things that the public came to the AMA with in the 1960s. So I boiled them down to kind of 3 core factors underlying each of these issues. And we're going to walk through how family medicine can work to solve each of them. So it's really, really well documented that health systems that are based on primary care have better quality of care, better population health, greater health equity, and lower cost. And they think that the reason that primary care is so well suited to fix things like this is because in its nature, it has this adaptability to its local environment, and you can adapt to you can adapt your practice to serve the needs of your community in ways that other specialties and other disciplines do not. And they also think that the reason family medicine is able to do that is because of this complex interaction with the following tenets of primary care. And so I've heard this thrown around a lot. Some people are like, oh, it's the 6 C's, it's the 10 C's, it's the 12 C's. It's the many C's of primary care. I chose a few of them. So this is what family doctors perform and provide both for their patients and the healthcare system in general. So they provide accessibility as a first point of contact for the healthcare system. They provide accountability for addressing a vast majority of personal healthcare needs, which translates to comprehensiveness. This is my favorite statistic to throw around. It's that a well-trained generalist, so a well-trained family doctor, can take care of 95% of any patient's given needs. The other 5% being things like neurosurgery, things that you need to go through a trained person for. Family doctors perform coordination of care across settings. They provide integration of care for both acute and chronic and often comorbid illnesses. They guide access to the judicial use of more focused care when needed. And they sustain partnerships and personal relationships over time with both communities and families. So how does this alleviate healthcare burden and costs? So other favorite statistic. Did you know that 50% of United States outpatient office visits are to primary care providers, but only 30% of US providers are primary care physicians? This means we have a huge gap in the need for primary care. Especially since greater primary care in a community is associated with better healthcare outcomes. And so I think this becomes pretty obvious why if we look at visits for specifically what are called priority health conditions. And so according to the WHO, 70% of global deaths are currently due to non-communicable diseases. These priority health conditions, these non-communicable diseases, are diseases of great prevalence that cause significant morbidity and mortality in the population. And when you compare the types of visits, or what visits are for amongst different types of physicians, we find that family physicians care for large numbers of patients with these priority health conditions. So these conditions that are most impactful to the burden of disease in our society. And so not only this, but the majority of these conditions can be prevented or mitigated by managing risk factors like smoking, alcohol consumption, physical inactivity, diet, and all of these things have in turn been shown to be responsive to primary care interventions. So family medicine is uniquely suited to impact the burden of non-communicable diseases. Because globally, the leading causes are these lifestyle factors, and these lifestyle factors are also influenced largely by social and economic factors, so things like poverty or social displacement or inequality of any shape or form. And this global burden, this burden impacts not only our own societies, but every society worldwide. And family doctors, because of their lens that views patients within the setting of their society, are, again, uniquely suited to solve these problems. And so you solve these problems using both a primary care approach, but also a secondary and a tertiary care approach, which I think is an important myth to bust about family medicine. It's not just primary care. You can work in a hospital, you can work in secondary and tertiary care settings. Maggie's shouting out because both of us want to be rural docs to do it all. Okay, so I think the big takeaway is about how family doctors can impact the burden of health, the burden of health, not the burden of health, the burden of disease, thank you, on our society is the fact that patients actually are proven to live longer when family doctors are added to a community, and that pattern does not hold true for when other specialists are added to a community. And so health outcomes are better when there are more family doctors. But guess what? It gets better. Adults with family doctors also spend 33% less per person on healthcare costs. So greater primary care availability in the community is also associated with a decrease in costs, as well as a decrease in utilization of the most expensive types of healthcare services, which are things like hospitalizations and ED visits. So this is kind of what I alluded to earlier. This is a graph of our healthcare expenditures compared to OECD countries, which are countries in the similar income and development bracket as us. And you can see here that we spend 2.5 times the OECD average. But the point that I want to make for illustration is we spend almost twice as much as Canada, a country very close to us in geography and culture. So obviously, the reasons for these exorbitant healthcare costs in the United States are multifactorial and super complex, and don't just have to do with the fact that we rely poorly on primary care in our healthcare system. But it is proven that strong primary care is the foundation of efficient, equitable, economic, and resilient health systems, and can address the majority of care needs for the majority of people, regardless of where they live. And so this better access, better quality, and better relationships with the patient translates to more informed and thus more economical decision-making, as well as more prevention and just lower costs in general. And so a large part of the discrepancy that exists in this graph is because we don't have a strong primary care base. So the United States has about 50% more specialists than new primary care doctors. And the vast majority of other healthcare systems in these similarly wealthy nations looks like this. So for comparison purposes, Canada only has 10% more specialists than primary care doctors, which means they aren't quite at this gold standard yet either, but they're doing a lot better than we are. So this is the same data presented in a different way. I really like this paper, and I can send it to you guys if you want it, but it's basically a score. They scored health systems based off of 9 characteristics and 6 practice characteristics that we can talk about later if you want. But you can see here that not only are our costs the highest represented on this graph, but we also have the lowest healthcare score. And if you take it one step further, we have the worst outcomes if you look at things like neonatal mortality and infant mortality. So our healthcare system currently only has 30% primary care providers, and 16% of those are internal medicine doctors doing primary care, and 12% of those are family medicine doctors. So which means only 12% could be primary care providers for like adults, pregnant women, and children. So 30% PCPs, 12% family doctors. But in 2010, the Department of Health and Human Services put out a report that said there's significant evidence that optimal healthcare outcomes and optimal health system efficiency is demonstrated when at least 40 to 50% of the physician workforce is composed of primary care physicians. So we have a long way to go. I also really like this chart because it is probably the easiest way to represent what I just spent the last 5 minutes saying. Here's the primary care store. Here's healthcare expenditures. Everybody else is on a line, and we are the outlier. But let's talk about the final pillar of the things that underlie the problems with our healthcare system, which is access. So where would we be without family medicine? Full disclosure, I 100% lifted these images and slides from the AAFP's website. So perhaps the most dramatic way to demonstrate the fundamental role of family medicine is to look at what would happen if family medicine disappeared. So many, like a large percentage of US counties are designated as primary care health professional shortage areas. And so these are counties where there is less than one or less primary care physician per 3,500 people in the designated area. So less than 1 per 3,500 people in the designated area. I'm going to show you what happens if internal medicine doctors leave. Only 2% of the countries that were previously blue turn red. So the pink ones are the ones that are already red, the dark red ones are the new ones that are red. So if all internal medicine doctors disappeared, only 2% of counties would become health professional shortage areas. So going back to the original map, this is like 5 years old, maybe, but this is the current situation. Now we're going to look at what happens if family doctors leave. So if family physicians were to disappear, the counties that were previously in blue and white, 58% of those would become health professional shortage areas. That's compared to 2% for internal medicine doctors, 0.5% for pediatricians, and 0.4% for OBGYNs, all of which are considered to be primary care specialties. And so these data demonstrate, without a doubt, that the United States depends on family medicine doctors more than any other specialty to deliver care to its population. And part of the reasoning behind this is that when your skill set is broad, you don't need as big of a population base to support a practice. Like if 1 in every 100 patients need a nephrologist, like you better live in a place that has several 100,000 patients. 100 out of 100 people need family doctors. All right. So family doctors, we've established that they are responsible for caring for the majority of our population, but I want to point out that family medicine is really good at making sure that when they care for the population, that means everybody in the population. Better primary care is also associated with more equitable distribution of health within a population. It's also more strongly correlated with better health outcomes. Like we know that it's associated with better health outcomes in general, but it has a stronger correlation with better health outcomes in areas with the greatest levels of income inequality, which suggests that expanding family medicine availability in these areas may have a more substantial impact on population health than expanding other primary care specialties. The data show that, I'm repeating myself. So the data do show that these findings are consistent across rural versus urban settings, across local versus state settings, and even when you stratify based on race. Family medicine doctors make more of an impact in areas with greater inequality. So moving on to how that applies to family medicine's role in alleviating health disparities that are prevalent in our country. In the United States, racial and ethnic minorities face greater difficulty accessing regular primary care than white Americans, is a fact. And they also use hospitals more than private clinics as their usual sources of care, and they also tend to have poorer health outcomes. These things are all related. So I wanted to share with you guys this study that they did on 24,000 adults, a little bit over 6,000 of which were of Latin origin. And they showed that these white adults were more likely to have access to a patient-centered medical home. So 57.1% of them were likely to have access. And then Mexican and Mexican Americans and Central and South Americans were least likely to have access. And when I say patient-centered medical home, that is a primary care family medicine clinic model where you can, it's a model of both providing healthcare and also measuring quality outcomes for a variety of different primary care services. Okay, so this disparity, a lot of what they saw, they thought was caused by lack of access to a regular provider, which led to lower rates of preventative care and less positive patient experiences, as well as worse healthcare outcomes. And so these healthcare outcomes that we usually see due to the myriad inequalities between white and Latin populations are eliminated when those Latin populations have access to a patient-centered medical home. And so when racial and ethnic minorities have access to primary care, their health disparities go away or are significantly reduced. I don't want to oversell. Okay. So now what do we do, right? Like we talked about how family medicine can help reduce costs, provide better quality, and provide better access. But we tried managed care. It didn't work really well. The WHO, the World Health Organization, published this amazing bulletin that I thought was really interesting reading about why managed care didn't really work really well in the United States. And it's basically because this is America, and we were coming to the table with this really strong free market bias and framework of our healthcare system, and what happened to managed care was essentially a product of this framework. And so the WHO goes on to talk about how it has been shown that managed care had an impact on slowing the growth of healthcare costs while preserving quality and also preserving physician income, physician reimbursement. So we know the data exists behind it, but it didn't work, and fee-for-service didn't necessarily work either, which is our current model, where you get paid in exchange for the amount of things that you do and the types of things that you do. Which incentivizes people to just perform more procedures and order more tests without thinking about quality and outcome. So managed care didn't work super well. Fee-for-service isn't working super well either. Several years ago now, the ACA, the Affordable Care Act, came on board, and what I didn't realize about the Affordable Care Act until people told me, was that once you kind of dig through all the political gunk that's surrounding it, its primary purpose was to increase access to primary care so that we could help solve all these issues we started trying to solve way back in the 1960s. So it did that by implementing measures to increase the primary care workforce, to train more family physicians, to make sure they got better reimbursement. It tried to increase access by expanding insurance coverage, and it tried to decrease costs. And so the reason that the Affordable Care Act, though, is unpopular with the American public are largely the same reasons why managed care was unpopular with the American public. Our dominant cultural pull in America is not towards the social responsibility and equity that drives other, namely European countries' healthcare system, but we are more focused on things like our personal liberties and competition and exceptionalism and consumerism in our healthcare system. And the Affordable Care Act doesn't provide that. So, you know, we know what we can learn from each of these, and we need to move forward. And we know that the pros of the American market-based healthcare system is that it's really great for innovation, not only in healthcare delivery, you know, we have some of the most advanced healthcare in the world, but it's also really great for the innovation of how we can measure and improve upon quality of our healthcare, and how we can incentivize people to provide better healthcare. And so the current camp of people who are working on these things, who are working on providing, you know, innovation and also quality healthcare, are family medicine doctors. So obviously we need to still increase the workforce, we still need to increase access, we still need to reduce costs, and come up with better, better payment models, basically. But the people working on this right now are family doctors. So I talked about the patient-centered medical home a little bit before. That's, you know, I actually don't know when patient-centered medical homes were founded, but it's a relatively novel thing.
I think it came with ACA. You get billed differently under the ACA.
Okay. So patient-centered medical homes are supposed to be just that, a home kind of similar to managed care, in that you have a primary care provider who is able to get you all of the services you need all under one roof, and even provides things like vaccination and dentistry and nutrition and counseling. The value-based care models is a departure from our previous fee-for-service models, where instead of getting paid for the number of tests you order, or the number of procedures you run, you get paid based on your patient outcomes. So that's how a lot of patient-centered medical homes are reimbursed. A lot of people are experimenting with direct primary care. It's a really interesting and evolving new field that is a whole other lecture in and of itself. And then finally, I want to talk about the quadruple aim. And so the quadruple aim is kind of what insurance companies and healthcare systems and everybody have decided that we should all be working towards as providers, like not even as primary care providers, just as providers. And the quadruple aim, the four things are patient experience, population health, care team well-being, and then cost reduction. And we're supposed to be working towards all of four of those things. And the only specialty that consistently works towards all of those things is family medicine, on a systems level. So we're back on the rise. Last year, 2018, was the 9th straight year that the number of graduating medical students going into family medicine increased. That's because it's a really, really good time to join family medicine in America right now. We need family medicine doctors, and with, you know, we don't know what is going to happen in our current healthcare landscape, but with the rise of the things that were inspired by the ACA, like patient-centered medical homes and value-based care, family medicine is really having their moment again. But it doesn't mean that, especially at large tertiary care institutions, especially medical schools, that you won't hear a lot of these myths perpetuated. You know, just because family medicine has a strong value does not always mean that it's valued at tertiary care centers. And we can talk about why these individual myths are false afterwards, but I don't want to spend too much time on it. I would like to tell a great story. So how many of you guys heard that NYU recently gave free tuition to like their incoming medical students? Yeah, right? So they did that to incentivize them to go into primary care, right? And they were really hoping that other medical schools would follow suit. And Yale, in response, like published a press release or something like that, stating that they wouldn't be doing that because our graduates will always be those who seek international recognition for their accomplishments and specialties. well, we recognize the value of primary care. We will leave it to the state schools to produce this workforce, is literally what Yale said in response. And so, you know, the culture of the 19th and 20th century is still very much prevalent, where we have this culture of elitism in the universities and in tertiary care specialty centers where family medicine is not valued or recognized. Like, I didn't know what family medicine was until I accidentally went to a shadowing opportunity. And even then, it took me 3 years to admit to myself that as a successful student, this is what I wanted to, you know, demean myself by going into. So the other fun fact I wanted to share is Yale is one of 10 medical schools in the country. Most of them are Ivy League, so do not even have a family medicine department, much less a family medicine residency. So hopefully that was enough to convince you to join family medicine. If any of this spoke to you, you know, join our family medicine interest group. You can find us on social media, on Instagram and Facebook. I usually retweet these things on my own Twitter, but we don't have an FMIG Twitter yet. We can help you find mentors in family medicine. We can help you get involved in shadowing. Our current shadowing program had to go on hiatus because they canceled the clinic that we were previously shadowing in, but we can find you opportunities if you want them. And then finally, the American Association of Family Physicians, it's no longer family practitioners because that was part of the facelift that they got after the managed care organization. People didn't respect them because they were practitioners, they weren't physicians, so now we're physicians. The AAFP is super, super active. They are the most politically active association of physicians in the country, and they are really, really welcoming of students getting involved. And so membership is free with the AAFP for students. So if you guys are interested in signing up, you can come talk to me after. And then finally, I included some relevant hashtags because family medicine is full of really inspiring thought leaders, and they all use these hashtags to tag their stuff across social media platforms. And so I would really encourage you guys to join the discussion. And that's it. And I want to just end by saying, obviously I hope you go into family medicine because we really need more family doctors. But whatever you go into, I think the really important thing to remember is that 95% of what influences your patient's health is the stuff that's happening to them outside the doctor's office. It's the stuff that's happening in the community. And so the more you can pay attention to that, the better off your patients will be. All right, that's it.
And it's 12.
And I finished early.
It's 12:43, so
Yeah.
I think we have time for a couple questions. If anybody has
Does anyone have questions? Yeah.
So I have two questions. They're unrelated. So the first one is, when you were picking your primary care specialty, did you consider other things like med peds or IM, and how did you decide between those? Which was the best fit?
For sure. I came into medical school once I decided I wasn't going to be a neurologist like I thought. I thought I was going to be a med peds doctor. And there's a little bit of tension between family medicine and med peds. Ultimately, what made the decision for me is that family medicine, the underlying philosophy of it, is what I really believed and ascribed to. And med peds does not have an underlying philosophy besides the fact that they are two academic specialties smushed together into one residency, and there is no continuity to how to care for your patients from pediatrics to adults. There is just both of those things at the same time, whereas family medicine provided that continuity and provided that overall broad lens view, basically. The other thing though is I was totally fine giving up adults and just being a pediatrician. I was this is really real, and I had a super crisis on my peds rotation this time a year ago. And we had this patient who came in, and actually she didn't come in because she wasn't allowed to come in. We got a call from her. I was on the endocrinology service, and she had come into Parkland in labor in new onset type 1 diabetes, so she was in DKA, and she was 15 years old. And so the OBGYNs didn't want to touch her because she was 15 years old and in DKA, and they didn't know what to do with these medical conditions. The pediatricians didn't want to touch her because she was pregnant, and the internal medicine doctors didn't want to touch her because she was a kid. And I was present as all of these consulting services were calling each other about this patient, and I was like, hey, this is a 15-year-old kid who just had a stillbirth and was diagnosed with a chronic life-changing condition, and no doctor is there for her. Everybody, she doesn't fit in any of these doctors' boxes. The only box that she fits in is family medicine. Family medicine doesn't decide what the box is for the patient. They let the patient tell them what the box is. So that was what changed my mind.
I just want to echo, like, you see this all the time, especially when you get out of the tertiary medical centers and you go a little bit farther out. And I'm not even talking far out, I'm thinking like Urbane or something like that. A lot of people, family medicine, we're not thought of as consultants, but when people have really complicated patients, they're complicated for a variety of reasons.
Mhm.
It's a transgender patient on hormone therapy who's receiving treatment for Hep C and just got AIDS. They have no idea who to call, so they call it family medicine.
Yeah. And I think this goes back to busting this myth. Like, family doctors do literally everything you can think of and work in any setting you can think of. I talked to a rural family doctor who was like, yeah, you know, back in the day, I like assisted on some pretty significant neurosurgeries that would definitely not fly anymore. But it would probably still fly somewhere.
You said you had a second question?
Yeah, I was gonna say.
Oh, yeah,
that
same
also
time.
one. But, so it's actually about that second one, about mid-level providers.
Oh, yeah.
So my cousin is a nurse practitioner, and we were just talking about, how, you know, there's a primary care shortage, and part of addressing that has been increasing the scope of practice for nurse practitioners and other mid-level providers. How do you, like, with all of the research you did on family medicine, do you see the scope of practice and that division between mid-level providers and physician, primary care providers? Like, what do you think will happen?
Yeah, so I have been really, really trying to form an opinion on this topic. I have asked almost every single family doctor I've ever worked with about it, and they all have differing opinions. But some things that have seemed to be true kind of throughout what I've spoken to is that until the education for nurse practitioners is standardized and formalized in a reliable way, they are not going to be like desired to take on an increased scope without physician supervision, because a lot of them like don't even have to do clinical rotations until they get hired as a job, basically. And you really need those like hours and hours and like repeat exposure to not miss this very step. And then also what I've heard from not only a lot of doctors who have told me this, but also a lot of mid-level providers, or I think they're supposed to be called something else now, like advanced practitioners is the PC thing. What I've heard from a lot of physician's assistants is, oh, like, we don't want to be doctors. Like, our job wouldn't exist without doctors. We want to work with doctors, and we want to, you know, collaborate with doctors, but we don't want to have independent prescribing, you know, rights or anything like that, because ultimately, like, that's not how we see our role in the healthcare system. I think the attitude differs a little bit for nurse practitioners, is my understanding, and they very much see nurse practitioning, or being a doctor of nurse practitionment, I don't know, as the like highest level of training in their field, whereas PAs see being a doctor as the highest level of training in their field. And so I do think there's a little bit of a discrepancy there, but my understanding is that like the training is not there, and people will always need family doctors. Plus, there's enough of a primary care shortage to go around, like hardcore. Yeah.
You just voted the other myth about you can only work outpatient. You mentioned you want to work in a hospital. How would that work?
Yeah. So basically, the second you get out of a tertiary care center like this, this does not represent the majority of the way the majority of care is delivered in the United States. And a lot of family doctors will go round on their inpatients in the morning, and then go to clinic in the afternoon, and then be on OB call that whole time, and then, you know, do some procedures in the afternoon, and then go, you know, a patient needs to be followed up on after clinic. Sorry. They will go around with the patients again. Yeah.
Okay.
So, and the cool thing about family medicine is like, that is one example, but literally you could take the mismatch, like a mishmash of anything you like about any scope of medicine, and you can build a practice that fits your interests and fits your passions. And so if you want to spend 4 days a week in the hospital and 1 day a week in clinic, you can do that as a family doctor. If you want to do 1 day a week in the hospital, you can do that as a family doctor. If you want to deliver babies but not do C-sections, you can do that. If you want to do C-sections, you can do that. So
The caveat to that is you really have to go into residency knowing that you want those things,
that's
so
true.
you can get the training. It's much harder to get the training once you're already through residency. It's still within your scope. It's not like an OB-GYN trying to do neurosurgery where they'd be like, no, we're not going to train you to do that. What are you talking about? If a family medicine doc wants to learn to do something, there are hospital systems and places that will help them earn the training to do that, but it takes a lot more work. So you go into residency knowing what you want to do, knowing you want to do LGBT medicine, knowing you want to do heavy on hospitalists. knowing you wanna do a lot of procedures, or you definitely wanna do OB-GYN, or you really wanna focus on peds, there are programs that will encourage and embrace and get you to the level of training you need to do all of those things.
Right.
It's just much easier if you know going into residency rather than trying to wedge that in sometime in your third year of residency.
The thing I will say to that is there are 519 family medicine residency programs. That is the most out of any specialty and discipline. So there is literally something for everybody. You can find a program that has a flavor of medicine that you are looking for. The other thing is there are fellowship training opportunities available to family doctors, which is not a myth that I put on there, but it is a myth. You know, you can't go into cardiology as a family medicine doctor, but that kind of undermines the idea of being a family medicine doctor anyway. And I certainly know family medicine doctors who just took it upon themselves to learn a bunch about cardiology and then take a bunch of complex cardiology patients that couldn't get in to see a cardiologist. That was another thing that convinced me against peds. I was like, well, you know, I really like kids with chronic diseases, I might want to subspecialize. And then I met a family doctor who halfway through his career decided he really liked cystic fibrosis, found a pulmonologist who was willing to train him, and opens up a CF clinic, and he works 1 day a week in his CF clinic working with CF kids. And I'm like, if family doctors can do this, like, I want to be a family doctor.
Yeah, I know a family doctor who only did allergies, he just worked as an allergist. That's his favorite thing to do, and so when he realized there was a big need for it, he lived in a bigger town, so long he does.
You do have to be a little bit willing to like kind of renounce the traditional structure of medicine, because I think we are drilled in that more titles and more prestige and more fellowship training and more formal certificates and whatever are better. They don't mean anything.
And if you guys have any more questions, you can always, I'm sure you've seen our emails on Maggie, we email all the time. We also have more events coming up. We're gonna do an ultrasound workshop next month. Exciting! Yeah. They stayed late. They like had to kick the cleaning ladies out last time.
Really?
Yeah, like the cleaning ladies were like, "Can we come clean the room?" And they're like, "Oh, we're still ultrasounding."
Yeah.
Last year, so yeah. So it should be a lot of fun. And we're gonna do some more lectures, and we have some like party events coming.
We do. I think more importantly though is we have another event tonight.
Oh,
More
that too,
importantly,
yeah.
The Family Medicine Grand Rounds is tonight. I think it's gonna be really interesting. I don't go to a lot of the Grand Rounds, but I really want to go to this one because it's about like the ethical situation surrounding those direct-to-consumer genetic testing. So things like 23andMe and the ones that are like telling you they're going to test you for which cancers you have and like which SSRIs are going to work for you. And I'm super interested to see what family doctors have to say about the ethics of that. So,
And if you guys have ever run about ground rounds before for like surgery or EM or something like that, ground rounds family medicine is way more chill. Like you don't have to sit in the back, you don't have to eat last, just go in, get food, sit down, say hi to somebody. Everybody is really
oh my God,
nice.
that's the number one reason to join family medicine. They're all like
Everybody is
like,
so nice. Yeah.
There's none of this like BS.
Yeah. Okay, cool.
Thank you, guys.
You can not sign in, please sign in more quickly, like, up under the chairs. And if you want to take some food,
Oh yeah, please.